The topic for discussion now is malaria. As we all know, malaria is one of the most one of the most usually encountered fevers, usually encountered fevers now and then, especially most commonly seen in areas of Asia, sub-Saharan countries, Africa, sub-Saharan countries, etc. Usually in UK and also in US. Also, most commonly, malaria has been one of the commonest fevers, one of the few commonest fevers that we actually come across. Usually it is a protozoan infection caused by Plasmodium falciparum, and this it can also be caused, most commonly associated is Plasmodium falciparum, and other common protozoans that have been also causing malaria are Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, Plasmodium novilacea, which is actually a simian parasite. And these protozoans has a vector which will actually transmit this one, and it is transmitted with the bite of female Anopheles mosquito. Female Anopheles mosquito is one of the common cause for transfer of this Plasmodium falciparum and thus causing malaria. Usually, as we have discussed, it is most commonly seen in areas like sub-Saharan countries, subtropics, and also in tropical regions. Usually, children and pregnant women are more commonly affected with this malaria. And travelers also have the susceptibility. More susceptibility has been seen in travelers. Here is a picture which is usually showing us areas which are most commonly affected. The areas in the brown are the area in the map, right? Those areas are most commonly affected by malaria. It is endemic in nature. So when people are traveling from these particular regions to other regions, because these are endemic of malaria, when these people are traveling from such countries to different countries, there is more risk of being other people who are coming here also, there is more risk of encountering this disease or getting this malaria. This is nothing but traveler susceptibility can be seen in case of malaria. Coming to the pathogenesis. Pathogenesis is the life cycle of malarial parasite. Normally, as we have seen, that female Anopheles mosquito is the vector which has been transmitting this the protozoan. It usually feeds on a human who is containing gametocytes, that is, person who is suffering from malaria, already suffering from malaria. On such patient, when the mosquito bites and takes the blood, it sucks the blood, which is the blood that are containing the gametocytes, and thus the mosquito will be infected with these gametocytes. These gametocytes will actually develop in 7 to 20 days within the mosquito, and they multiply in time and give rise to sporozoites. These sporozoites actually are accumulated in the saliva of the mosquito. When such mosquito bites another person, these sporozoites will again enter into the human blood, infecting the other humans. Normally these sporozoites, what happens is when the mosquito actually bites us, these sporozoites will enter the blood, and from blood they usually disappear within half an hour of time. Usually within 30 minutes of time they disappear and they enter into the liver. Whenever they are entering into the liver, this is called as liver stage, and there they develop into merozoites. These merozoites will again enter into the blood and they attack the RBCs. Okay, when they attack the RBCs, this is called as erythrocyte stage, and these merozoites develop on these RBC and they develop and they attack the RBCs. The RBC which is being attacked by these merozoites are called as schizoids. Okay, these are called as schizoids, and they thus multiply in number and they release more and more amount of merozoites into the blood. In this erythrocytic stage itself, patients usually will have fever. Plasmodium vivax and Plasmodium ovale are other common reasons for malaria, and these are responsible for malaria. But what happens is there is a small difference in the pathophysiology of this. Plasmodium ovale and Plasmodium vivax will actually persist in liver instead of going from liver into blood. Okay, they are usually present in a dormant form within the liver, and these can develop into merozoites later. So, if patient is being infected with Plasmodium vivax or Plasmodium ovale, these, as they remain dormant within the liver, they can multiply in number or they can actually become active in a future period of time, causing malaria then. Okay, they need not be an immediate malarial action in case of Plasmodium vivax and ovale. So here is a picture which actually shows us Plasmodium life cycle. So it has two stages. One is mosquito stage and in the body of human. In the mosquito stage, what happens is when the mosquito sucks the blood, it will actually the infected gametocytes will be present and will be taken by the mosquito from a human blood, there it will actually undergo changes, such as it forms into macrogamete initially, then into microgamete. From there they actually will these microgametes, and they have this multiplication process and they develop into a zygote. After this zygote is being burst, they release number of sporozoites. These sporozoites will enter into the salivary gland. From there, when this mosquito, which is having sporozoites within the saliva, within the salivary gland, bites another normal human being, the sporozoites from the mosquito saliva enter into the human body. There what happens is the sporozoites are usually present within the blood for half an hour. From there they enter into the liver, which is actually called as liver stage, and there they infect the hepatocytes, and there within the hepatocytes they develop into merozoites. Number of merozoites multiply there and they burst, giving rise to merozoites into the blood. Once these merozoites enter into the blood, they attack the RBC, which is called as erythrocyte stage. Here what happens is merozoites enter a asexual cycle where the infected RBC with the merozoites usually forms a ring stage first, then they become a trophozoite. After this trophozoite, the RBC completely is now called, RBC with the trophozoites is now called a schizoid, and there it releases more amount of merozoites. These merozoites at this stage have a capacity to cause fever, and in the erythrocytic stage, fever is a manifestation. Now these merozoites which are present, they undergo a sexual differentiation where they form into gametocytes. Okay, so in the human blood again they form into gametocytes. These gametocytes will again be, when a mosquito bites this infected person, the gametocytes from the human infected person will be entering into the mosquito, and the same cycle follows. So this is a plasmodium life cycle which is happening both in the mosquito and human body. So this is a picture which is actually showing a clear picture of the life cycle of malarial parasite, where the sporozoites are being converted into merozoites and then to gametocytes, and these gametocytes are again in the mosquito are converted into sporozoites. Okay, this picture is a life cycle of the malarial parasite. Normally this Plasmodium falciparum and Plasmodium malariae, there is usually no persistent exoerythrocyte stage in this. Usually they have a particular recrudescence of fever which may occur after multiplication of parasites within the red cells. When there is a multiplication of these parasites, then they will have a recrudescence of fever, that is reoccurrence of fever in case of Plasmodium falciparum and Plasmodium malariae. Normally the pathology of this is, whenever the red cells with malaria is involved, whenever the malaria in this condition, what happens? There is excessive hemolysis is present. That is, there will be breakdown of the RBCs. In Plasmodium falciparum, they invade the red cells of all ages, especially young cells. That is, in Plasmodium vivax or Plasmodium ovale. In this condition, Plasmodium ovale will affect the reticulocytes. Plasmodium malariae, the normoblast. And in pathology, what happens is there will be anemia because of this hemolysis. Red blood cell hemolytic anemia can be seen in these cases. There will be dyserythropoiesis, and that is the production of erythrocytes is again stopped. I mean, there will be discrepancy in the production of red blood cells, and also there will be a condition like splenectomy, and decreased folic acid levels can also be seen in these cases of malaria. So these are the various pathological features that are usually associated with that of malaria. Now coming to Plasmodium falciparum, whenever Plasmodium falciparum affects, there are certain conditions, that is NOP proteins. One important feature is NOP proteins, where NOP proteins are something that these red blood cells which have been infected with the Plasmodium falciparum, they go and attach it to the vascular endothelium. So these, instead of flowing within the lumen of the blood vessel, these red blood cells which have been affected with the Plasmodium falciparum will go and attach it to the endothelium. This is nothing but NOP proteins, and they follow, they enter into a phase of, they develop as rosettes and with rolex with the uninfected cells. What is this rolex formation is, this infected RBC will go and form stacks of RBCs with the normal uninfected cells. This condition, what happens when there are multiple RBCs being accumulated in one region forming rosettes and rolex, they cause congestion of vessels leading to organ damage. Later they release toxins and also antigenic substances, which is again harmful condition. Coming to the protective mutations, normally as we have discussed, this Plasmodium falciparum will attack the red blood cells. In case there are certain protective mutations that are happening, especially in case of sickle cell anemia, sickle cell will not be able to form rosettes or rolex because the discoid structure is already lost in this condition. The biconcave structure of RBC is already lost in case of sickle cell anemia. And conditions like thalassemia, G6PD deficiency and HLA-B53 mutations also. In these mutations, these conditions, what happens is Plasmodium falciparum infecting an RBC is usually less. So they actually have a protective mutations in these conditions. This is a picture which is showing Rolex formation, where we can see stacking of these RBCs here, which they are forming a clumping or group-like formations. Normally, Plasmodium falciparum usually does not replicate well in hemoglobin F, hemoglobin S. Hemoglobin S is nothing but sickle cell hemoglobin. Hemoglobin F is fetal hemoglobin, and hemoglobin C. Hemoglobin S heterozygotes are well protected against malaria. As we already know, sickle cell anemia is more predominantly seen in African countries. In those people, affecting with malaria is usually less. Okay, so Plasmodium vivax cannot enter cells without a Duffy blood group, especially in Western African and African Americans. Usually they are not been affected with this Plasmodium vivax. Now coming to the clinical features. Usually it is a non-specific condition, non-specific symptoms or non-specific manifestations are seen. There are no specific manifestations in this condition. In Plasmodium falciparum, usually they have potentially fatal. It is an insidious origin onset. You have vomitings, headache and malaise are most commonly associated with this condition. Cough, mild diarrhea, fever, sweats, chills in the night. Patient wants to have a blanket around and sleep. There will be jaundice. Jaundice is because of hemolysis, okay, and also hemolytic anemia can be seen in these cases. There will be hepatic dysfunction, tender, enlarged liver and spleen can be seen. That is nothing but hepatomegaly and splenomegaly. And thrombocytopenia is also been associated with Plasmodium falciparum. These are some of the symptoms of malaria affecting various systems and having various systemic manifestations. They will have headache, fever, fatigue, pain, back pain, muscular pain, that is nothing but myalgias. Patient usually have chills, they'll have sweating, profuse sweating can be seen after a phase of chill phase, and they'll have dry cough. There can be enlargement of liver and spleen, and patients will have nausea and vomiting. Now coming to the complications, apart from normal clinical features, that is the clinical features which are non-specific, this malaria has a particular or pathognomic complications which will include cerebral malaria. Cerebral malaria, the clinical features include seizures, they'll have confusion, coma, and there is no localizing sign seen in case of cerebral malaria. Normally, they'll have increased mortality in children. If at all, if malaria is been occurring in case of pregnancy, then there will be impaired immunity. If it occurs in early stages, there can also be abortion or growth retardation of the child. Parasite can bite into the placental protein, that is nothing but chondroitin sulfate. Hence, intrauterine growth retardation can be seen in these cases. In case the patient has undergone a splenectomy or previous splenectomy, in those cases also risk of complications of malaria is enhanced or increased. Coming to Plasmodium vivax and Plasmodium ovale. In this condition, what happens? It actually starts as a continuous fever for a long term for several days. Then classical bouts of fever on alternative days. The pathognomic feature or a classical feature of Plasmodium vivax and Plasmodium ovale is there will be continuous fever for a particular period of time. Later in that, there will be bouts of episodes. There are classical bouts of fever on every alternate days. So this is a feature of pathognomic feature of Plasmodium ovale or Plasmodium vivax. Patients usually have rigors, they'll have chills, and the temperature also is raised above greater than about 40 degrees centigrade. And after half an hour or so, there will be hot or flush phase can be seen in this case. And hepatosplenomegaly, tender enlarged liver and spleen can be seen. Patient will also have anemia. Normally, this can relapse after first 2 years. Why there is a relapse? We have already seen in the pathogenesis that Plasmodium vivax and Plasmodium ovale can enter into a dormant phase. That is the reason there can be relapse in the first 2 years of after infection. Coming to the investigations, Giemsa stain both for thin and thick blood films is useful. Thin film is usually confirmatory, and thick will allow us. Thick will show thick blood films usually will detect even low level parasitemia can also be detected in case of thick blood smear. And Plasmodium falciparum and Plasmodium vivax has a characteristic ring-shaped RBC, and scanty and ring form in RBC can be seen in case of Plasmodium falciparum and Plasmodium vivax. Other tests include immunochromatographic studies, especially for malarial antigens, and this include optimal and parasite F. QBC malarial test is also present, which includes fluorescence microscopy based malaria diagnostic test, and DNA detection with PCR can also be helpful in identifying malaria. Now coming to management. Earlier, chloroquine was the first line of drug, but chloroquine resistant malaria has been seen in near days. Actually, with the advent of chloroquine in the years 1950 and 1960, they have thought that malaria can be abolished completely, can be can be treated or it can be cured. But unfortunately, because of the resistance to this chloroquine and sulfadoxine pyrimethamine, what happened is the malaria has spurged again in the world, and there is a massive attack of this malaria. So in case of mild Plasmodium falciparum malaria, artemisinin based treatment is being followed nowadays. Here what happens is co-artemether, which includes artemether and lumefantrine, which are 4 tablets which are given at 0, 8, 24, 36, 48 and 60 hours. And these during these periods when co-artemether was given, in those cases malaria can be actually been cured in these cases. Quinine by mouth, doxycycline, that is 200 mg, which is given for 7 days. Clindamycin given for 450 mg 3 times daily for 7 days can also be given, which is also can also be helpful in treating mild Plasmodium falciparum malaria. Other cases, other drugs such as doxycycline and artemether, which will have to be avoided in pregnancy because they are contraindicated in pregnancy. And artesunate, which is about 200 milligrams per 3 days, and mefloquine, which can be given as 1 gram on day 2nd and 500 milligram on day 3rd, can also be used for treating mild Plasmodium falciparum malaria. Coming to complicated case of Plasmodium falciparum malaria, here also when parasite count is greater than 2% and it is actually a medical emergency, has to be treated on immediate basis. Anti-malarial treatment, which has been discussed earlier, plus management of the complications, fluid electrolyte balance has to be maintained, and avoid any harmful ancillary treatments is the protocol of therapy in case of this complicated malaria. IV artesunate can be given for 2.4 milligrams per kg body weight, IV at 0 hours, 12, 24 hours, and also then it can be given once daily for 7 days. So this is also will be helpful in treating complicated Plasmodium falciparum malaria cases. Now management of non-falciparum malaria, that is which has been caused because of Plasmodium vivax and ovale. In those cases what happens is management is through oral chloroquine. 600 milligram chloroquine base can be given, 300 milligram in 6 hours, 150 milligram has to be given twice daily for more than 2 days. And radical cure with primaquine has also been observed along with oral chloroquine, which can be given as 15 milligrams daily for 14 days, which actually destroys the hypnozoid phase in the liver. So those dormant phases within the liver can also be killed with the help of this primaquine, and hence relapse can be minimized when treated with primaquine when compared to that of chloroquine. However, whatever the management may be, prevention is always better than cure. So, what are the preventive measures? WHO preventive measures. WHO has given certain preventive measures that can be helpful in clearing of malaria. And most commonly used preventive measures are insecticide treated bed nets. So, these bed nets are known to, and many evidences have shown that these insecticide treated bed nets will be helpful in clearing malaria, in preventing malaria condition. Electronic mosquito repellents are most commonly used ones, but these there is no much evidence showing the efficacy of this electronic mosquito repellents. Other treatment is intermittent preventive treatment in case of pregnancy. So there will be repeated dose of prophylactic drugs in case of high risk groups, and these drugs can be chloroquine, mefloquine, doxycycline and melarone. Now coming to this is about malaria, and this is about the clinical features of malaria, different etiological agents, their pathophysiology, and how this actually can be treated and prevented. So this deals with malaria. Now let's go to the next topic, that is rubella. So rubella is another common condition which was usually seen in older days, and nowadays it is not much seen. And rubella is also called as German measles. It is again an exanthema which is usually seen in non-immunized persons, and generalized rash on the body is most common feature of this disease. And it is usually spread through respiratory droplet infection, and incubation period is usually 15 to 20 days period of time. The common clinical features associated with rubella is nothing but fever, maculopapular rash and lymphadenopathy. This is a picture showing a small child, an infant with skin lesions because of congenital rubella. And the most common complications that have been associated with it are thrombocytopenia, hepatitis, encephalitis and hemorrhages. Usually in women, arthritis is one common cause which has been associated with rubella. Rubella is known to cause a transplacental infection in first trimester. It can cross the placenta. Whenever there is an infection in the first trimester, then patients can have, then the infants or the fetus can have a congenital disease. There will be increased incidence of development of other diseases also in this children who are being infected with rubella during pregnancy, especially diabetes mellitus. There can have increased incidence in these cases. Coming to the congenital malformation risk, if the child is being infected or if the mother, pregnant woman is being infected in the first trimester, then they can have spontaneous abortion and multiple abnormality defects, congenital defects can be seen in these cases. If at all a pregnant woman is being infected with rubella in the 3rd month of time, then they can have single congenital defects. These single congenital defects include deafness, cataract, glaucoma, or it can include a congenital heart disease, mental retardation and pulmonary stenosis are various other clinical conditions, clinical features associated with this congenital malformations. Now, if it has been involved in 4th month period of time, usually deafness, and 10% of these patients will only 10% can have congenital defects. So, if the pregnant woman is being infected with rubella in the first trimester period of time, there are multiple congenital abnormalities can be seen. If the woman is infected after 5 months of time, after 5 months of pregnancy time, then it will be occasionally deafness can be seen in these cases. Congenital rubella syndrome is a condition which has been pathognomic triad, which will have sensorineural deafness. They can have abnormalities of eye, which will include cataract, retinopathy and microphthalmia, and congenital heart diseases, which is nothing but patent ductus arteriosus and pulmonary artery stenosis can be seen. Here this is a picture of the child, of an infant who is showing cataract because of congenital rubella syndrome. So the most common, how actually we have to diagnose this rubella. Normally clinical features will help us to come to a provisional diagnosis, and the diagnosis can be with the help of detection of this rubella IgM antibodies within the serum and IgG conversion. This will help us in diagnosis. In pregnant women who are being exposed, absence of rubella specific IgG will help us in identifying congenital infection. Prevention can be with the help of a MMR vaccine, which is a combined MMR vaccine for measles, mumps and rubella. This vaccination will be helpful in preventing the condition, that is preventing rubella in adults and children. However, if it has been affected, if the pregnant women are affected, then congenital rubella syndrome can also be seen in this patients who have been congenital rubella syndrome can also be seen. So this is about rubella, its clinical features, pathophysiology, how congenital rubella syndrome and how infants are being, how the severity of this congenital rubella syndrome can be seen based on the time of attack, that is based on time of infection during pregnancy. How the severity is present is also been seen, and diagnosis has been discussed with the prevention. So this is about rubella.